Okay, Hi everybody. I would like to welcome all of you from all over the world to our fourth webinar. Today, our webinar will be about arthroscopic anchorless transosseous versus anchored rotator cuff repair. First of all, I would like to welcome all our great speakers from all over the world: Dr. Assassi, Dr. Bassem Frega, Dr. Brett Sanders, and Dr. Christopher White, and Dr. Kovacs, who still hasn't joined us yet, and Dr. Sri Kumaran. Also, I cannot see him. Well, actually, I would like to start immediately because in order not to run out of time, and I hope that you all enjoy our webinar today, and I'll pass the mic to Dr. Bassem Frega for his welcome speech.
Good evening to Africa, Europe, and the Middle East. Good morning, good afternoon to America, and good late evening to Asia. I am Bassem Frega, president of the Egyptian Shoulder Society, and I am very happy to open the fourth webinar of our young society. And I want to thank all the colleagues who viewed our recent webinars from all over the world. And I want to thank very much the members of our society who made a great effort to make these webinars successful. Last webinar, there were about 1,374 viewers of our webinar. 70% of them were from 82 countries from all over the world. This gives us a responsibility and stimulate us to work harder to present more efficient and more scientific, high-quality webinars. I want to thank also the participants, Dr. Christopher White from Oklahoma, or from Oki, as my teacher Charles Neer usually said, I am an Oki. I want to welcome Dr. Brett Sanders from Tennessee, Dr. Oma Sri Kumaran from Johns Hopkins, Dr. Kovac from Frankfurt, Dr. Mohammed Al-Assasi, and Dr. Ahmed Andil from Egypt. And I want to give the microphone to my friend, Dr. Ahmed Kantil, to start the moderation of the webinar. Thank you very much for all of you.
Okay, thank you, Dr. Bassem. And now we're going to start our webinar. Our first speaker will be Dr. Mohammed Al-Assasi from Cairo University. He will give us a talk about history and development of rotator cuff repair. Please, Dr. Mohammed, would you unmute the mic, please? We cannot hear you.
Okay.
I think we have a technical problem with Dr. Mohammed Al-Assasi. I hope that we can resolve that in a few minutes. If not, I think we may proceed to the next speaker. Okay, I think because we don't want to run out of time, sorry for this technical problem. So I think it's better to move to Dr. Christopher White. He's going to give us a talk about the anatomic single and double row rotator cuff repair. You can proceed, Dr. Christopher, and thank you very much.
Good evening. Can everybody hear me?
Yeah, we do. Okay. I can hear you.
Perfect. Well, let me get my talk up. And that's coming in okay?
I can hear you fine.
Okay, good. So again, I want to thank everyone for inviting me to be back and to talk this evening or afternoon or morning, depending on where you're at. And I was tasked in discussing the arthroscopic single and double row rotator cuff repair techniques. And this is a topic that is near and dear to me because I am a surgeon that uses anchors routinely for rotator cuff repairs. Again, I'm from the University of Oklahoma. And yes, Dr. Neer was from Veneta, Oklahoma. And I'm and actually, anyways, I'll move forward. So just to discuss the reason this is a big deal and a very important discussion is just to understand the burden of rotator cuff disease in our practices and across the world. And in the United States alone, over 4.5 million visits are estimated to be to U.S. physicians for shoulder problems. As of 2016, and this is probably closer to 500,000 repairs now, but as of 2016, there were over 400,000 repairs of rotator cuff tendon tears in the U.S. alone every year. And it is the most common surgery that I've performed in the 15 years of practice since leaving my fellowship. And if we do the math, that's over $6 billion spent in the United States on rotator cuff repairs each year as things stand. Just real briefly, this is a very, very large topic. If you just look at the burden of information that we could discuss about the rotator cuff, if I just do a quick Ovid literature research or search on the term for rotator cuff, we get over 11,000 studies returned with the topic, including rotator cuff. If you specifically search for rotator cuff tear, you get over 3,000 studies that have been published based on the Ovid search. And then if you combine rotator cuff with shoulder arthroscopy, that's over 1,000 papers that have been published on the topic. So clearly, I don't know everything from every study, and I can't, we have to have some constraints to a 10-minute talk on what I'm going to talk about. But hopefully I'll talk about the subjects that are most pertinent to our discussion today. So I just wanted to just briefly put in and define the scope and design of my talk. And the point is here to discuss an overview of the basic principles of the rotator cuff repairs using anchors, to discuss some of the most common...
Dr. Christopher, I'm sorry, but did you share your screen or you just... we do not see your slides. I'm sorry.
No, I'm so sorry. I did. I'll try again. Is that better?
Yes, that's perfect, sir. Thank you.
Yeah, we can see it right now. Thank you.
I'm sorry. I apologize for that.
No problem.
The scope here is to to discuss some of the most common techniques used in rotator cuff repairs with anchors, and to provide some evidence of the efficacy and safety of these techniques, and to discuss some of the comparisons between single row and double row constructs, and to provide some insights as to how I employ these techniques into my practice, being a man or a surgeon that uses anchors routinely. What I won't discuss is, there's a huge, this could be, of course, talks into their own, but to discuss the multiple anchor designs, the different composition of anchors. I'm not going to discuss the various sutures and tapes used within these anchors or discuss the comparison of anchors to true transosseous techniques. Obviously, that'll be discussed later in our webinar here. if we look at the goals and principles of a rotator cuff repair, well, really, our goal, of course, is the patient. We're aiming to get the best functional outcome we can, or clinical outcome for our patients. So we're aiming to reduce or alleviate pain. We're trying to restore their motion and their strength, return our patients to their activities, and minimize the economic burdens of our efforts to do this, to accomplish the above. And we're also trying to avoid complications, of course. And to do this, the principles of treatment, we're trying ultimately to provide an environment that is favorable for tissue healing and restoration of anatomy. And to do this, we need to be able to recognize tear configurations for appropriate repairs, and this requires adequate visualization. We need secure fixation of the tendon to bone, approximating the tendon to bone at the repair site, and to resist initial displacement and have a stable construct for as long as it takes for the tendon to heal, and to allow adequate surface area contact for appropriate healing. Our repairs need to be tension-free or as low tension as possible. And of course, there's many described and discussed mobilization techniques, and we need to try to promote the biology of healing best we can. So there is some value of having gray hair, and I've had the fortune of being able to, through my training and my career, to kind of span open techniques to many open techniques, ultimately to being mostly arthroscopic or almost exclusively arthroscopic now. So when I did my training and residency as a junior resident, we performed open acromioplasties and rotator cuff repairs routinely. As a senior resident, we were performing shoulder arthroscopies largely for diagnostic reasons, but also for acromioplasties, but performing most of our rotator cuff repairs mini open. When I moved to my fellowship with Mr. Bell in Melbourne, we did arthroscopic acromioplasties and distal clavicle excisions routinely, but almost all of our rotator cuff repairs were mini open with a hybrid construct fixation with titanium needle anchors and lateral transosseous sutures with PDS. But now, 17 years later, 99% of my rotator cuff repairs are arthroscopics, and indeed, I use anchors to accomplish that. So you can ask yourself, one thing I think is worth mentioning, I don't want to disenfranchise the folks that still occasionally or routinely do open or mini open rotator cuff repairs. I know this is a bit of a dated study, but I think the sentiment is still largely true, and that is that this study would state, and I think we can echo that, we haven't proven great advantages or differences between these techniques in terms of functional outcome. And as of this JBJS article in 2007, they can't say that one technique is definitively superior to the other. So I think there's probably still is a role for mini open and open rotator cuff repairs. And I thought that was just worth mentioning. But what's changed in my practice given that? Well, I think the tools have certainly improved from when I began my practice and my passage through my career. We have now a whole host and multitude of different anchors that allow us knotless and knotted fixation constructs. We have easier ways of passing the suture through the tendon. And overall, we have more tools at our disposal to perform these rotator cuff repairs arthroscopically. Over the years, I'm sure my skills have improved to make this a more easier technique. And frankly, now I'm much more facile, I believe, arthroscopically because I do those so much more frequently than an open repair. The techniques, I believe, have made me more comfortable. I think you can debate whether they've improved. I think they have, and I think the literature probably supports that. But initially, we had single row repairs. And then eventually we moved to a more footprint type of repair design with the classic double row. And that really made, since I was trained to appreciate and to want a larger surface area like a footprint style repair, that made me more comfortable moving into the arthroscopic arena for my repairs when we had double row techniques. And now we've moved on to transosseous techniques, linking the medial row sutures to the lateral anchors. And I believe that has certainly made me more comfortable with performing my procedures arthroscopically. But also important, and I can't deny, patient expectations have changed. I don't think these two nice elderly or late middle-aged people would be too happy with me putting a large incision on their shoulder when Dr. Joe Blow down the road will just use a couple of small poke holes and cameras and instruments and do the repair. So certainly patient expectations have changed as well. Well, if we talk about the broad categories of rotator cuff repairs with anchors, we largely divide these into three areas. We have single row techniques where you use a single row of anchors with suture fixation or tape fixation, perhaps, to the rotator cuff, and then the classic double row where you'd have a medial row of anchors and then a lateral row of anchors, each with their independent sutures or points of fixation to the rotator cuff. And ultimately, we've developed transosseous equivalent that are linked double row constructs, which link the medial sutures to the lateral rows mechanically. And we can subdivide this category into basically knotted transosseous equivalent techniques where the medial knots are tied, and then knotless techniques where the medial rows are not tied and affixed to and definitively to the lateral row anchors. So just a word about this: not all single row constructs are the same. And this makes it a bit difficult to compare, of course, in the literature, and because the anchor position could be medial, as in just a standard medial repair, but a transtendinous partial articular sided tear, or even Dr. Snyder's SCOE row, where he has medial anchors and a lateral series of bone vents inducing this crimson duvet, or biologic, or to enhance biologic healing. And then there's you can place the anchors in the middle of the footprint, with or without medialization of the footprint. And then you have placing the anchors on the lateral part of the footprint as well. When we talk about double rows, we talked about the classic double rows with 2 rows of anchors, each linked to the tendon with their own sutures. And then we have the linked double row constructs, or the so-called suture bridge constructs, or the transosseous equivalent. And again, these are subdivided into those with where the medial sutures are tied for points of fixation, or when the medial sutures are not tied and have knotless fixation medially. And the basic principles and the reasons for developing transosseous equivalent are: number one, to maximize the pressure contact of the tendon to the bone, to decrease the tendon strangulation because the lateral tendon is not penetrated by sutures, to preserve the vascularity over the lateral tissues owing to the absence of lateral knots, to avoid crowding the footprint with multiple anchors, so the second row is placed off of the tuberosity footprint laterally, and to mechanically interconnect the anchors for better load sharing and less tension mismatch with any given anchor with rotation, and also to prevent synovial fluid access to the rotator cuff footprint, as opposed to a single row, particularly one placed laterally or medially. So what do we know? What can we find in the literature that tells us how these two different basic constructs, or three constructs, perform against each other? And this is probably the best summary I can find, which is a 2019 review article from the Orthopedic Journal of Sports Medicine. It's a summary of basically single row, double row, and transosseous equivalent techniques. And it compares the biomechanical characteristics of all these different constructs. And it looks and summarizes the meta-analyses of level 1 and level 2 studies comparing single row and double row rotator cuff repairs. So what are the mechanical differences between the single row and double row techniques? Well, in this article, they reference Meyer's paper where it showed that the double row fixation more consistently reproduces the area of the footprint. And again, this was one of the reasons I was more comfortable with moving to arthroscopic repairs, being a footprint person myself. Dr. Park discussed applying more pressure to the contact area with the repair with double row techniques. And then there's multiple studies that have looked at strength and resistance to gap formation and stiffness and resistance to failure under cyclic load. And the double row obviously outperforms the single row. And this is not a surprise, of course. The biomechanics should improve or increase with more sutures, more points of fixation, and larger surface area of contact. Well, what do we know about the mechanical differences between the classic double row and the transosseous equivalent techniques? And there is some evidence that the transosseous equivalent does outperform to some degrees. Dr. Park, ultimate load to failure was higher in the knotted transosseous equivalent techniques versus the classic double row. And there was more contact pressure and overall contact area and greater pressure with the transosseous techniques. And Dr. Hada, an arthroscopic article in Arthroscopic in 2016 talks about more uniform stiffness distribution across the repaired rotator cuff tendon with knotless transosseous equivalent techniques versus the classic double row. So overall, the transosseous equivalent techniques appear to have more favorable characteristics than the classic double row techniques. What are the mechanical differences in the various transosseous equivalent configurations? And there's controversy about this of whether you should tie the medial knots or where you shouldn't. There's been some studies that have suggested less gap formation, less failure to load, and prevention of synovial fluid leaking onto the rotator cuff footprint with medial row knots when you tie those. Other studies have showed no significant differences in the resistance to ultimate and cyclic load failures between the knotted and knotless versions of transosseous equivalent. But we need to understand that the knotless repairs were largely developed to address the concerns of the primary failure of our repairs being at the muscular tendinous junction, the so-called type 2 failure. So what are the outcomes in between that we have between the double row and single row constructs? And this is a summary of the meta-analyses of level 1 and level 2 studies in the literature. And I'll go quickly through this because we're obviously limited by time. And I'll go through all these studies. And in general, if you look at some of these studies show no significant difference, and I think that's worth noting. But in general, if you have tears that are greater than 3 centimeters, the functional outcomes appear to be better in double row techniques. There also tends to be a trend for more re-tearing with single row techniques, particularly the partial re-tears following surgeries. And there's concern that these partial re-tears, although they may not have any functional or effect on the functional outcome in the short term or medium term, as these progress perhaps to full thickness tears, the functional difference may be more different between the single row and double row techniques. So what do we know about the summaries comparing the different double row constructs? So looking at functional outcomes and healing rates between the transosseous equivalent and the classic double row techniques. And if you notice in this column, there's absolutely no significant difference between the different double row techniques when it comes to functional outcome. Re-tear rates, there's conflicting difference. Some favor the knotted and some favor the knotless transosseous techniques. So not great data guiding us, which perhaps is better associated with less re-tearing of the rotator cuff. So just basically in conclusion, the biomechanics, relative to the biomechanics, there appears to be biomechanical superiority of the double row techniques to the single row repairs, and that shouldn't be a surprise. There are theoretic advantages to the transosseous equivalent techniques over the classic double row techniques. And some research, at least biomechanically, has shown that that's indeed the truth. But there's less clear advantages biomechanically between the various forms of the transosseous equivalent techniques. When it comes to functional outcome and healing, one thing I didn't point out and I think needs to be brought out is that both the single row and double row techniques are successful surgeries in improving patients' functional outcome, and that's pretty universal. The data would suggest, though, that tears that are greater than 3 centimeters have a better clinical outcome with double row techniques. Re-tears of the tendon are more common in single row techniques, especially the partial tendon re-tears. And there doesn't appear to be, or we haven't proven any significant clinical evidence in superiority of any specific double row techniques over the others. So what do I do? Just putting this all together, and how do I employ anchors in my practice? Well, for partial articular-sided tendon tears, I typically do transtendinous repairs with in a single row, and unless it's very extensive. Like I had a patient earlier this morning where the entire supraspinatus and a bit of the anterior infraspinatus was avulsed, and there was still some lateral tendon, so technically it wasn't a full thickness tear. But it's a large surface area, and I wanted a larger surface area for healing, so I placed 2 medial row anchors, and then I used a single lateral row to compress the lateral tendon against the footprint for a larger surface area for repair. When it comes to bursal-sided partial tears, I complete the tear and repair the rotator cuff tear as a full thickness tear. And a full thickness tears, if they're quite small, less than 1 centimeter or a centimeter or so, I'll use a lateral single row. If they're full thickness and they're more than about a centimeter, I am a footprint guy. And so if they can be easily mobilized over the rotator cuff footprint, then I'll use transosseous equivalent techniques with tying the medial sutures. Now, if I have massive tears that despite extensive mobilization can't medialize well or under a lot of tension, then I'll perform a single row repair medially and medialize the rotator cuff footprint and use triple loaded anchors, very similar to Dr. Snyder's SCOE row. So just some final thoughts. I think tension is the enemy of healing. I'm not in favor of crowding the area for healing. I think margin convergence is a technique that make daunting rotator cuff tears much more easily managed. And I feel it's important to be flexible in your techniques. I doubt there's one single technique that can address all of your rotator cuff repairs. I know there's lots of fans of knotless devices.
White, please, it's time, please, Dr. White. Can you?
Oh, I'm sorry.
No problem.
Anyway, just real briefly, I just want to say my concerns: economic burden of the implants, burden of the anchors and the greater tuberosity, and I'm concerned that there's more I can do to promote biology. So thank you very much.
Well, thank you very much, Dr. White, for your nice presentation. I think we can go back to Dr. Assassi if he's ready with his presentation. Dr. Assassi, are you ready? Or
Yes, I'm ready, Dr. Ahmed.
Okay, go ahead. Thank you. Please be on time because we are running out of time. Thank you very much.
Okay. Okay, you can see my presentation, Dr. Ahmed?
No, unfortunately, we cannot see your presentation.
Okay.
I would like to ask all participants to
Can you see me now?
No, not yet. Don't hesitate to ask questions, and I'll be more than happy to pass it to the speakers. So you can just type in or write down your questions, and I'll be more than happy to pass it to the speakers. Thank you. Do you still have a problem, Dr. Assassi?
No. You can see me now?
No,
Okay.
Unfortunately, no.
No. Okay, proceed to another lecture, and I can manage that with COP. Okay.
Okay.
Thank you, Dr.
No problem. So now I think we're going to move to Dr. Brett Sanders from Tennessee. He's going to talk about his new technique. I think it's a true transosseous hybrid technique. Is it right?
That is correct.
Yeah. Okay. Good. So you can start, Dr. Sanders, please.
Okay. Everyone can see and hear me okay?
Perfect.
Awesome. Thank you so much for inviting me to discuss one of my passions. This topic is something I've explored a lot and spent a lot of personal time on. And I'm from Chattanooga, Tennessee, and we're going to be talking about a true transosseous hybrid rotator cuff repair. And I have a relevant disclosure. I'm the founder of a company that makes a reusable transosseous tunneling device. When we talk about our ideal repairs, this is straight from Christian Gerber in the 80s. We want initial fixation strength to resist ultimate and cyclic failure. We want to prevent or reduce gap formation and adequately assess shear forces. But we also want to restore the footprint, which I think we're doing here. This is a transosseous repair. We want to be able to have multiple fixation points to reduce these deformities, the bird beaks and the dog ears, and have anatomy that's restored. And you need multiple fixation points to do that in addition to load share. We also, I think, need to be mindful of bone voids and surface area for healing and the biology that imparts to the healing of the repair. There's been an anchor-induced failure mode recently caused by TOE type repairs, which causes a stress riser here medially and leads itself to an anchor-specific failure mode, which is catastrophic, called the type 2 failure. I think we need to be aware of that. And that creates a revision scenario that's quite difficult in some cases. And we want to have good results. And of course, but I'd like to introduce perhaps some new ideals. I think we should be looking at improved healing responses and the biological healing that can be quantified on MRI and the healing characteristics that we get. We want to be able to utilize our patches and the biology that's probably the key to repair, but under the surgical cost ceiling, because we can't just keep adding in these things. They're too expensive, and it's just not practical in most of our systems. We'd like to have improved vascularity, which has been shown with transosseous repairs to be excellent. We also want to match the modulus, not exceed the modulus, and we want to restore the footprint. And we've known for a long time that transosseous repairs are the best way to recapitulate the footprint. And through this transosseous cerclage effect, we also want to be mindful of cost. We all have to have this optimization equation of time versus cost versus quality and implants and surface area and all these things. And every cuff repair is a problem that we have to optimize. This concept of load sharing, I think, is very important. So multiple fixation points instead of pressure spikes is going to be very important to redistribute the load mechanically. I started into this topic with an interest in value as defined by the Harvard Business School as outcome over cost per episode. Many of you are in single payer systems already, and this has been a problem in the United States. We've managed to hide the cost problem through a very complicated third-party payer system, but we've definitely had technological convergence and commoditization of implants. You know, an anchor is an anchor; they're commodities, and something that can provide a non-inferior, it doesn't even have to be superior, just a non-inferior outcome and cost effectiveness offers superior value. And we're in a prime zone for that in shoulder. E.A. Codman, the person who repaired the first rotator cuff, was measuring this, you know, even back in his early days, and talking about this got him actually kicked out of Mass General. So this has been around for a while. Randelli and Castagna out of Italy introduced me to this rotator cuff repair cycle. And we have transosseous. So there's a logical progression that progresses from transosseous open back to arthroscopic. This is the transosseous cerclage effect. It's the best way to restore the footprint. We came to mini open with anchors, doing the same thing, but adding a lot of hardware cost. And then when we came to the arthroscopic repair, we went to single row anchors. And this is where we had a lot of problems with outcomes and an inferior repair. And then we added extra anchors to recapitulate the transosseous repair, adding a lot of cost and adding a new failure mode as well. And where I'm trying to work,
I can learn to understand you much better.
I think we may need to mute.
Dr. Kovacs, can you just mute Dr. Kovacs? Would you please? Yeah, thank you.
So, we're at the transosseous equivalent down here in the bottom left. And what I've worked on is this hybrid technique to try to step surgeons who are used to anchors into adopting transosseous techniques, which have many advantages, and to go fully transosseous arthroscopically again, and come back to this same methodology with less cost and a lot of clinical and biological advantages. Initially, when we went to arthroscopic techniques with single row especially, they were disastrous failures in terms of outcomes. This has been shown with 90% or 80% failure here with these studies on the left. And why they failed, whether you're a biologist or more of a biomechanics maven like Burkhardt or like Snyder here, a biologic approach, tension and biology on the left, is up for debate. But the solution that came to the fore offered by the industry was a biomechanical solution with the transosseous equivalent. We've just heard that discussed. And these very smart authors came up with this, and this was a natural evolution, and they were comparing this to double row, not transosseous, fully transosseous. It was double row anchors. And they say in their paper that they were exactly trying to recreate the traditional open transosseous cerclage effect. And compared to double row, these anchors created more mean pressure over the footprint in the lab, and they had a higher load to failure with no more gap formation. They had 400 newtons or so versus 300 newtons or so. And in their paper, they state that 302 newtons is the theoretical force which we wish to achieve. That's the contraction of the supraspinatus. So that's really all you need for healing. And the advantages that they list in their paper here talk about lower profile knots than double row, not relying on the torn tendon edge for fixation, reducing surgical time, placing anchors, eliminating some of the anchors from the healing zone, load sharing, interconnecting fixation points, lateral fixation, which is orthogonal to the force vector. And I realized that all of these could be achieved with transosseous approaches, actually. And so this is where we have stepped now into the hybrid technique, which I'm about to show you. We have known that the transosseous, many people here on this webinar might agree that the transosseous repair is the gold standard. The giants of cuff repair have done this forever, but there's a lot of interesting things coming out in the modern times about biology, biomechanics, pain, revision considerations, and synergies with other hard fixators that are quite interesting and sort of updating this technique, I would say, for the modern era. This was written up. This is a hybrid technique that was written up in 2007 already with 400 or 500 newtons. And this is the first one I did arthroscopically, and I just recapitulated this technique. And again, your cuff repair methodology is an optimization of time, cost, fixation, usability, and what you can do in your hands and your system. But this was the first repair I did, just recapitulating what was already a strong construct in the literature, using basically biomechanical rationale, just as the TOE repair had done. Now, this is a slide on the right from the ESH meeting in 2018 or so. And in the green box, you can see this is Brian Cole's slide from Rush, showing that the transosseous equivalent with anchors has failure of 350 to 400 newtons. And this paper from Bernie Bach and Gus Mazzacca, who are smart researchers, called the multi-suture technique, shows that using all suture, you can actually double that, 856 newtons. So you won't have this shown to you by anchor companies, but they were ripping the surgical neck off the specimens with only suture. And so this is my version of this arthroscopically using hybrid techniques. And so I think we can achieve this now arthroscopically. The biomechanics of transosseous is different than anchor points. And we don't have this. Funakashi has shown with finite element analysis that there's a stress riser. And Sano has shown that that goes away with transosseous versus these pressure spikes that cause type 2 failure, essentially peak loading right into the area where the tendon can't heal. And this is why you get some of these re-tears, because it's exceeding, not matching the modulus. Scott Rodeo, one of the smartest researchers in the business, has shown, among others, that, and Shu Kumaran on this call has shown this as well, that suture number determines the strength. It's not the anchors. And so now that we can put a lot of suture in arthroscopically and easily, I think we're going to be able to address this concern. I would implore a lot of the thought leaders on this webinar to think about moving the paradigm from rows to fixation points per surface area and number of sutures per fixation point. This is what was not controlled for in the original studies, and it caused a lot of confusion. What's important is fixation points per surface area and number of sutures, not anchors. And so using these principles, basic principle thought, we devised this true transosseous hybrid technique. And so this is a triple row, if that matters, technique. You can see in the cartoon on the bottom left picture that has no anchor burden at the footprint. So it's only microfracturing, which is the only thing that's been shown to enhance healing actually biologically. So you have bone marrow vents, you have improved surface area for healing, and you have better revision considerations because you don't have inert material in your healing zone. that you have to work around. It's triple row, but it's independent fixation. So you have knots fixing a transosseous X box, and then you have an independent anchor backing it up. So you're not relying on that lateral row anchor like you are, for instance, with a knotless transosseous equivalent. If you believe that there's problems with weak bone, you have bone augmentation. And if you're having trouble with tying knots or appropriate tension, that lateral row anchor allows you to tension the construct at the last step, retension it. And you have an improved cost per fixation point. So you see we're getting 5 fixation points here, but we could easily get 7 or even 9 if we wanted to expand this and put in more tunnels and just use 1 or 2 anchors as the surgeon wants. And this is also a self-reinforcing construct. So the more force that's imparted orthogonal or perpendicular to the construct, the more it compresses that surface area. So this is the same principles that we have just been discussing are important for cup repair are all now being applied at a reduced cost or a better cost ratio. This is what it looks like arthroscopically. You would think there's 4 or 5 anchors in there, and there's no anchors in that healing zone. This is all transosseous with 1 anchor down laterally. And this is my 14-month data of 143 patients. We had 4% re-tear. We had much less pain, about 2 VAS points less. And you can see this is SOS data showing the reduced pain when we changed to transosseous. We had a over 40-point increase in the ASES score. So excellent outcomes. And interestingly, 92 ASES scores, which matched perfectly Fabian Plaschel's study recently from Herbert Resch's data in 2019 JBJS. It was interesting. So very high ASES scores from this technique. So I'll take you through it here with a live first-person video. Here we're cleaning out the lateral gutter. Here's the Transosseous device that I use through a small portal. We pop in through the subdeltoid fascia here. We've already made the medial tunnel, just like you would for an anchor. We use an awl to make a 2.9 millimeter tunnel here. We find that tunnel and place the Transosseous device. It's quite stable. You see I can let go of it, and the assistant deploys it within about 20 seconds. So that's how long it takes to make a transosseous tunnel. So I think we've solved the time and usability problem there. And now we're going to bring the suture, the shuttling suture, out of the medial portal. This is now our shuttling suture, and we can shuttle tapes or sutures as the surgeon desires. I prefer the triplet. 3 sutures is the functional moiety of my repair constructs. It's a good balance. And here we clip the suture to the Coban in static mode inferiorly and in dynamic mode superiorly. So we let them slide superiorly and we don't let them slide inferiorly. And then we have topographic management. So what's happening on the outside of the patient is happening on the inside. And this is how we keep track of our sutures. Here is what the triplets look like from inside. You can see the monitor there. And then we're going to exclude the inferior sutures with the cannula. So this makes a suture management setup exactly like anchors. And now you're just dealing with the superior suture. So it's very easy to pass your sutures in any manner you desire. And here we're going to link the tunnels. So we talked about linked constructs. So we're linking the constructs. Some surgeons have concerns about knot tying, so we're going to tie this outside the cannula. So it's a simple knot tying exercise outside the cannula here, square knot backed up with alternating post half hitches. And we're simply going to tie those and pull them back in and manage those sutures from the top portal. Next, we'll tie simple sutures. I use an SMC knot with the knot low and lateral. We keep the knots off the top of the tendon, mostly for cosmesis. But that's a sliding locking knot. Here, interestingly, you can put the knot stack where you wish to make the compression optimized and to make the repair look nice and optimize compression. You can't do that with transosseous equivalent. And then we're going to secure the crossing sutures, again, by grasping the crossing sutures outside of the cannula, and we'll tie that knot again outside the cannula. Now you could pull these in and go ahead and cut these sutures and you'd be done. That would be a Transosseous X box. But what we're going to do is we're going to reduce a little dog ear here using the cannula to make it look perfect. And here we've left our tails long and we could be done here. You can see we're moving our repair side. It's got good shear stability, excellent footprint reconstruction. And we're going to take these tails that we've left, and this is going to give us a second chance to back up the construct independently with an anchor and also retension the construct in a knotless fashion. So we're going to bring this down in a self-reinforcing construct below the horizontal mattress limb. This is the triple row, and we're going to put that in as you would any standard anchor, but it's just one anchor, and there's no anchors in the healing zone. So you see it's quite solid, and here it is from laterally. And we do that in about 15 minutes or so. It's time equivalent. Independent studies have shown that. Lazarus and Black have shown that independently. So that's the repair. And these are the outcomes we get. We're getting excellent outcomes with these patients with much less pain. And we had a webinar last night about this. The bone pain, we think, could be coming from anchors and the bone marrow edema, which has been shown to last for about 6 months. And we simply just don't get that with transosseous repairs. And there's level 1 data out of Italy showing decreased pain. And here's an example of a cuff repair I did, and the radiologist read it as a normal cuff. So this is 6 months post-op. And the little white thing you're seeing there is a ferromagnetic artifact. So they can't even tell this cuff has been repaired. It's so natural in the healing. So I think that's very interesting. So there's a lot of interesting things to discuss.
Please time, Dr. Sanders, please time.
Okay, so we'll finish there. Thank you.
Okay, thank you very much. I do appreciate it was a very nice presentation, very nice technique, and I think we're going to have lots of questions at the end. Move to Assesi. Are you ready, or still there's a problem?
Yes, Dr. Ahmed. Yes, Dr. Ahmed, I'm ready.
Okay, can you start, please?
Yes, okay. Just a minute.
Okay, now we can see your presentation. Perfect.
Okay. Thank you, Dr. Ahmed. Thank you, Dr. Basim. Welcome our guest speaker. I will talk today on the history and development of rotator cuff repair. Next. First description of rotator cuff tear is credit for first description rupture of this structure is often by Smith, published in Medical Gazette in 1834. Next. First description of subacromial bursitis is the first to observe this is Gerjavi in 1867. Next. Periarthritis humerus scapularis is introduced this term by Duplay in 1872. Describes stiffness and pain in shoulder. Next. Goodman contribution. First cuff repair done by Goodman in 1909. First recommended early operative repair of cuff was Goodman in 1934. First proposed intrinsic theory is Goodman in 1934. And Goodman is the first describes the lesion partial articular surface tear. Next. First to describe subacromial pathology is Peterson in 1942, published a valuable observation on subacromial pathology. Next. First open suture technique was done by Goodman in 1911. First to report successful simple transosseous suture rotator cuff repair. And McLaughlin, who is the first to use matrix transosseous suture in 1944. Next. Different types for repair are done by Goodman, by McLaughlin, by Neer, by Hawken. Next. Factor causing rotator cuff tear, either extrinsic theory or intrinsic theory. Extrinsic theory is down-sloping acromial spare, acromial clavicular osteoarthritis, or intrinsic theory with suboptimal cuff vascularity, or oxidative stresses, or degenerative microtrauma, both lead to degenerative tear. Next. Extrinsic factor causing rotator cuff tear. Next. Next. History of open treatment of extrinsic factor, subacromial space, was the first advice Watson-Jones in 1939, complete acromiectomy. Then Smith-Peterson in 1943, hemiacromiectomy. McLaughlin advised lateral acromiectomy in 1944. Stam advised glenoid neck inferior osteotomy. And Neer in 1972 advised decompression and removal of the anterior spare. Next. Impingement syndrome. In 1972, Neer described the impingement syndrome. Neer classic work advocated extrinsic factors. Next. Impingement syndrome described by Neer in 1972 divided into 3 stages. The first stage, edema and hemorrhage. The second stage, fibrosis and tendinitis. Third stage, bone spare and the tendon rupture. Next. Bigliani in 1984 reported a relation between the shape of the acromion and subacromial narrowing and divide the 3 shapes of acromion: flat, curved, and hooked acromion. Next. Treatment of extrinsic factor causing rotator cuff tear. Next. Neer in 1983 anterior acromioplasty, wedge resection of the anterior acromion. Next. Mostly done open rotator cuff repair, tendon as about 10 cm incision, transosseous suture repair as performed by McLaughlin in 1944 and Neer in 1972. Next. Evolution of arthroscopic treatment of impingement syndrome and rotator cuff tear. Next. Evolution of shoulder arthroscopy position. Next. In 1984, lateral decompression position are described by Ullman. Next. Warren and Beach's chair are described by Warren in 1988. Next. Sitting position are described by Dr. Flega in 1991. And the advantage of this position is acromion parallel to the floor, match the X-ray, and the arm and hanged and free manipulation. Next. Arthroscopic subacromial decompression. Next. In 1985, first arthroscopic subacromial decompression by Ullman. Next. In 1995, arthroscopic classification of the space between the anterior acromion and the supraspinatus by Dr. Flega. No impingement pathology when the space is more than 1 cm and 2 mm. Next. Dr. Bassem Flega in 1995 gave the standard arthroscopic subacromial decompression by using the measuring needle. Put the anterior measuring needle anterior to the acromion and decompress until the space become 1 cm and 2 mm. Next. The mini open arthroscopic repair is described by Levy in 1990. Gave 80 and 100% good excellent results. Patient undergo many open rotator cuff repair, and but its disadvantage was scarring and stiffness, and can't address massive tears. Next. Arthroscopic rotator cuff repair using staple and anchors. Next. In 1988, the first arthroscopic cuff repair was done by Johnson by using staples, and the problem with this is the impingement and loosening of these staples. Next. In 1990, the first arthroscopic anchor fixation was done by Wolf by using Grammatic suture anchor and done in 1990. Next. Arthroscopic anchor fixation improved and propagated by Wolf, by Snyder, by Bochert, by Ace. Next. Anchor suture technique either single row or double row. Next. The first transosseous arthroscopic rotator cuff repair described in 1990 by Dr. Flega allows the same type of footprint cuff repair as open procedure. Next. Keep on in 2006 describes the transosseous equivalent, the suture bridge using the 2 medial anchor and 2 lateral push lock. The bridge configuration provides compression of the rotator cuff to the footprint. Next. After that, many methods are described to transosseous repair as Taylor stitch by Pellegrini in 2012. Next. Using of ACL guide also as a method for transosseous repair. Next. Curved Basser by Beauchamp in 2007. Next. Alessandro in 2018 makes this study in the history and development of transosseous repair. The transosseous repair, arthroscopic transosseous repair, started by 2002 by Dr. Pfleger by using of giant needle, and end 2017 by using of Compasso. Next. Recent shift to arthroscopic transosseous repair causes. Next. Double row versus single row. Kim et al. Compared single row and double row repairs with respect to cyclic loading, gap formation, failure loads, stress at anchor site. Compared with single row repair, double row repair had 4,200% less gap formation, 4,600% more stiffness, and 4,800% more ultimate load to failure. Next. Arthroscopic transosseous repair. More recently back to the past with transosseous footprint reconstruction. Current biomechanical studies found improved ultimate load to failure, reduced gap formation during cyclic loading. Next. Arthroscopic transosseous repair. Banker et al. In 2011 fact in that transosseous repair technique fuses the advantage of arthroscopic surgery, minimal collateral damage, to the strength of open repair. Next. This study done by Gerber in 1994 measured the repair strength of transosseous arthroscopic technique is superior to anchor technique. Single row tensile strength of 208 Newton. Double row repair strength at time 0 was reported to be 336 Newton. Transosseous equivalent repair was as open 443 Newton. Intact supraspinatus tendon 800 Newton. Next. Transosseous versus double row versus single row. San et al. Compared the stress distribution by using single row, double row, and transosseous. In transosseous repair, the stress was concentrated at the attachment site to the bone, and no stress was seen on the bursal side. On the other hand, single row repair had a highest stress concentration on the bursal side in the anchor area. A similar pattern was seen in double row repairs with the stress more concentrated in the medial anchor. They hypothesized that the high stress concentration seen in single and double row technique at the anchor site may explain the high rate of recurrence seen in anchor repair. Next. Summary: anchor versus transosseous repair. The advantage of transosseous repair improved the ultimate load to failure, restoring the footprint, achieving the best pressure on the repair. This advantage of anchors: less load to cause failure, gap formation, stress at anchor site. Next. New challenge: removing the anchor, loosening, infection, tear recurrence. Next. Thank you.
Okay, thank you very much, Dr. Assassi.
Thank you, Dr.
For your presentation. I think now we're going to move to Dr. Kovacs. Are you ready, Dr. Kovacs? He's going to give us a talk about arthroscopic transosseous rotator cuff repair. Would you please unmute? We cannot hear you, Dr. Kovacs. Would you please unmute?
Okay, do you hear me now?
Yes, we do. Okay. Thank you.
I have some problems with the presentation. I think I need some support with the presentation. I can go in. Did you hear me?
What's the problem exactly?
I have a problem with the presentation. I can make my presentation. I'm blocked somehow.
Okay, I think
I get some support. I sent you the email my presentation too, so somebody has to have my presentation.
Okay, I think in order, we can move to Dr. Uma Srikumaran. If
Sure. Yeah.
Are you ready, Dr. Srikumaran?
Yep. Let me share my screen and we can.
Yeah, perfect. So we'll just move to your talk.
Okay. Can you see the screen okay?
Yeah, perfect.
Okay, great. Hi, thank you, Dr. Fliga and Endil, for inviting me. It's an honor to be here and a wonderful webinar, amazing attendance as well. So I'm going to just talk about the comparison of what we've learned already from our prior panelists, this transosseous equivalent with the arthroscopic transosseous technique. One second here. So my disclosures are on the AAOS website. So with respect to the evolution of rotator cuff repair, we have evolved from an open to arthroscopic approach, and our constructs have also evolved. Initially, the open approach made use of this transosseous technique, and anchors allowed us to transition to an arthroscopic technique. So these constructs evolved, of course, from single to double row, and finally to a suture bridge technique. We label it as transosseous equivalent, as we've heard. So suggesting there may be something preferred about our initial simple and very elegant transosseous construct. The question now is, can we combine this transosseous technique with an arthroscopic approach, and should we? So just to quickly recap, the technique for a transosseous equivalent is placing that medial anchor near the articular margin, following that by bringing the sutures through the medial aspect of your tendon, and then bringing that into a lateral row of anchors. So you're achieving that compression or that suture bridge, it's often referred to. What you do medially, there are some options, whether you tie or you bring them directly in a knotless fashion. That, and compared to this transosseous construct, is very similar. If you follow the steps, you're still making a medial tunnel near the articular margin. Instead of an anchor, you're using an instrument to connect these two tunnels vertically and laterally. And this device has proven to be quite reliable and effective. And you can pass the sutures, as Dr. Sanders mentioned, in a very similar fashion and whatever you're comfortable with. And that, again, we're achieving this compression across the cuff accordingly. So you have that full now transosseous approach done arthroscopically, tying simples or all the complex different capabilities that Dr. Sanders showed us as well. So to quickly review the biomechanics, what do we know about these two, this transosseous equivalent now specifically, and the fully transosseous approach? Both can achieve very high failure loads, 578 newtons for transosseous equivalent compared to 468 for a transosseous in one study. And there's decreased gap formation with respect to TOE, and compared to transosseous, which has typically larger footprint coverage and a lower rate of that type 2 catastrophic failure that's been mentioned in several different studies. In our own cadaveric study here, you can see an example of that type of failure. This would be a very difficult thing to fix in a revision situation. In our TOE construct, the majority of failures were that type. Compared to our transosseous construct, the majority were type 1 or regular tears right off the bone that are much easier to fix in a revision situation. The failure mode has also been looked at and found that the mean intensity of perfusion is significantly lower in the transosseous equivalent group. So the initial conclusions are the anchored transosseous equivalent constructs does demonstrate a slightly higher failure load, but an anchorless transosseous repair can also achieve very high failure loads. And Brett mentioned the importance of suture. And so we have to evaluate this, and that's what we did, looking at a true systematic review of all those papers. All these 40 separate biomechanical papers and authors have looked at this. And so we combined that in a systematic review and meta-regression and looked at the suture parameters as independent covariates, as well as the construct type, TOE, single, double row, or truly transosseous. And our dependent variables were simply failure load and mode. So, of course, as Brett mentioned, the strongest predictors of repair strength are your number of sutures, not just that, but the number of limbs of the same suture that pass through the tendon, and also the type of suture. So wide dimension suture like tape is actually better at distributing and holding the force than typical sutures. And when you control for that suture material, there's no difference in rotator cuff repair construct strength between any of these different techniques that we use. And the other findings, again, we find that the TOE construct is associated with higher type 2 muscle tendon junction failures. With respect to contact area, and that was the goal of the transosseous equivalent, it's been shown to have more favorable compression in some studies and force compared to other anchor designs, but that compressive ability really goes hand in hand with tying the medial row. And when you do that, that may be a cause of that muscle tendon junction failure and that constriction. So there's quite a little bit of a conundrum here with the transosseous equivalent approach. When we look at this contact area, the potential advantages of this repair are that you can still achieve this high contact area, favorable compressive pattern, and high contact pressure in multiple studies. And that pattern does not require any stress loading on the medial side, because everything can be done in a simple suture configuration. So this is important to balance that compressive ability to limit your muscle tendon junction failures. So if we look at our clinical experience, Brett Sanders mentioned the Randelli randomized controlled trial. That was comparing a single row, but I think, as Dr. White mentioned, the transosseous equivalent would be considered the gold standard for anchored approaches. So we compared that, and we published this year in Core, a direct comparison of this transosseous repair versus a transosseous equivalent double row suture bridge repair. And we did this in a retrospective fashion with minimum 2-year follow-up. We were able to match, however, sex, age, tear size, importantly, as well as smoking status. And our primary outcome was the minimal clinical important difference for the ASES score. Other outcomes included the VAS pain scale, range of motion, the SSV, as well as repair integrity. And that was done by ultrasound with a blinded radiologist reviewing all the cases. And we had 100 patients with, again, minimum 2-year follow-up. And as Brett mentioned, all the results we found were non-inferior or essentially equivalent with respect to 1-year and 2-year ASES scores, 1-year and 2-year subjective shoulder value scores, as well as VAS pain scores. Range of motion was very similar across groups, and there was no statistical significance. And the ultrasound evaluation of re-tear rates, again, similar and only correlated with tear size and not technique. So in conclusion, both groups can achieve very clinical, meaningful results, statistically significant improvements, both at 1 and 2 years now. And we're collecting our data for 4- and 5-year follow-up for this same cohort. And there's no significant difference in the procedure duration, re-tear rates, or clinical outcomes. Of course, it's a limitation. It is a retrospective review with a single surgeon. So the takeaway points, I think, that when you look at the biomechanical literature collectively, you can achieve similar strength just by the suture. And the numbers of the sutures and the type are what is important to consider. The transosseous equivalent repairs increase the risk of type 2 failures, and may have a worse compressive pattern than transosseous repairs. Clinically, arthroscopic transosseous versus TOE repairs can both achieve good clinical outcomes with low re-tear rates. As Brett mentioned, as one is quite significantly less costly, that represents a much higher value for arthroscopic transosseous repairs. Thank you.
Wow, that was fast. Thank you very much, Dr.
Catch up.
Yeah, you're trying to catch up. Yeah, you're right. So thank you very much for your presentation. Back to Dr. Kovacs. Are we ready, or we still have a problem?
No, I still have a problem.
Okay, so we move to Dr. Bassem Frega with his talk.
Yes. Okay.
So Dr. Bassem, are you ready?
Yes, I'm ready.
Okay, so the talk of Dr. Bassem will be about 30 years experience with arthroscopic transosseous anchorless rotator cuff repair. You may proceed.
I will actually talk only about technical tricks and my experience in the 30 years as I'm using the transosseous repair. My first connection with rotator cuff repair was through a visit to Dr. Neer in 1981. He told me that the golden standard is the open rotator cuff transosseous tendon repair. In 1990, I tried to use an anchor for the arthroscopic repair. At that time, it was only a single repair technique, but I was faced with problems which I thought I can solve it in another manner. So I said, I will try to do the transosseous repair arthroscopically using a technique, and that took me about 1 year of trials. Then we finished with the giant needle technique of transosseous repair. It is a technique using a special needle through the skin, through the tendon, and out through the bone, and out again through the skin. The instruments used are a giant needle and a strong needle holder, sometimes also a suture puller, and a so-called suture catcher, and an owl. The positioning is very important. The patient is in a sitting position with the arm hanging in order to push the needle with gravity. A subacromial decompression is done for all cases. I usually decompress the subacromial space to be 12 millimeter, as my colleague said before. First, we do remove the periosteum from the footprint area, and then with an acromializer make a bleeding surface. After that, we go with an owl inside the joint. I make a hole at the junction to the cartilaginous head. Then the needle is passed through the skin, through the tendon, and then pushed in the hole made before. Then it is stepwise pushed inside the joint, inside the bone, and then also pulled out in a stepwise manner while holding the elbow with my left hand. The two ends of the suture are pulled out through the instrumentation portal. A sliding knot is made and pushed with a concave knot pusher inside the joint to fix the rotator cuff. Sometimes I use the chop needle puller, passing it through the skin in the subacromial space, and then through the tendon, and pull the suture from its entry in the bone through the tendon. I can also use the chop needle catcher and puller to place a suture in the soft tissue. In the partial tear, I usually detect the tear by using the back of my shaver and feel the hole in the tendon. Then with a hook, arthroscopic hook, I try to perforate it. If I succeed, so I have to make a repair. The repair is done by removing the damaged tissue and suturing the rest of the tendon with transosseous repair. The same thing is done for pasta lesion. And in case of supraspinatus full lesion, that's what we call, because we found that at the end of the supraspinatus, sometimes there is like a ballooning or a weak area with no tear, no partial tear. So we cut this bad tissue, and the histology showed that there's increased fibrosis in it. What is the reason? We have to know, but we remove it and then we do a reefing of the tendon. In small and medium-sized tear, we do the standard transoscopic repair with a giant needle and also an end-to-end repair. If you have a U-shaped repair, it's like we close an end-to-end and make the tear smaller, and then do the transosseous repair. With an L-type repair, we first pull the tendon to the place where it used to be and see if it is possible. Then we put the suture in this place and pull the suture with a chop puller through the tendon and tie the tendon, and then do the rest of the transosseous repair.
Hello?
Sometimes the biceps tendon will be tenodized laterally in case of large tears or massive tears, and suture the remainder of the tendons on it. In case of Erb's palsy, we have sometimes a redundant totally of the supraspinatus through superior migration of the head. So besides the decompression and resection of the protrused greater part of the tuberosity, reefing of the tendon is done. This reefing is also using the giant needle and chop needle puller. We make a T-shaped incision on the tendon, and then we make a cruciate repair by suturing above each other. Here is with water inflow, you see the tendon is bulging, and after repair, there is no bulge of the tendon. The infraspinatus, the same thing. We pull the infraspinatus as much as possible upwards to see where it will be, and then we place a suture using a giant needle, and then with a chop needle puller, as here we go through the tendon and pull the suture through the tendon, and then tie it to the tendon. We can make a more fixation with a suture wire technique to make a mattress suture added to it. In the subscapularis tear, also in the same manner, we place first the suture upwards, and then with a chop needle, we pull the suture through the tendon and tie the subscapularis upwards. This is how we do this mattress suture technique with the wire. The biceps, a bicep synergies is done using the giant needle transosseous fixation by making a raw bleeding area on the tuberosity and the sulcus, and then suturing the tendon to this area, and after that, cut the remainder of the biceps inside the joint, or use the remainder for reconstruction of the remainder of the rotator cuff in cases of large rotator cuff tears. In case of a bicep with distal displacement of the tendon, make a small incision down and then pull the stump of the biceps tendon, put a suture in it, and pass through the arthroscopy portal. You pass an arthroscopy grasper and grasp and pull the sutures up to get the tendon in the sulcus inside the joint, and then we suture it with the giant needle transosseous fixation. The knot I use for repair of the tendon is the giant knot. It is a sliding self-locking knot. You make the knot outside and push it inside the joint with a concave knot pusher. And then after placing it, we pull on the loop, and the knot will be blocked. Basic principle for massive tears: manipulation under anesthesia, superior capsule and lateral release, arthroscopic capsulotomy, and rotator interval release. Here we see the upper part, superior capsule resection and loosening of adhesions, and then we pull the tendon to try to bring it to the footprint area. Synthetic patches are talked about recently in many places. I just want to say my experience of this way of technique in the 80s. In the 80s, we used to use the fasciolata or the Kennedy lat and other synthetic material to cover the defect on the supraspinatus. But it all failed. The reason why was that when we cover the PSA, it is 6 centimeter. Normally, with active elevation, this will be 4 centimeters because of the contraction of the muscle and tendon. Now, if you place it with a non-dynamic contractible tissue, so the head will migrate superiorly and cause superior migration because the distance will remain the same. And that was the problem. We did a late study on large and massive rotator cuff tear. We reviewed 55 cases from 97 operation with an average follow-up of about 15 years. The patients were average age 54 at surgery and at 69 at follow-up. Range of motion and strength was examined as well as the sonographic evaluation. The results, about 17% still had good and excellent result. 13% has unsatisfactory results. The deterioration with time was presented by 15% of the cases, but the patient satisfaction was approximately similar in early results and late results. Revision of suture anchor repair. This challenge is mainly how to remove the anchor. We find that the best way is using an awl and make space around the anchor, and then with a clamp, we remove the anchor. Afterwards, we repair the cuff by end-to-end suture, and then a transosseous repair, putting the sutures in the sound bone area between the holes. The rehabilitation, 6 weeks passive, either the patient is in abduction brace with a large tear or a small tear with sling. Then another 6 weeks of stretching and active self-assisted exercises, followed by vigorous stretching and strengthening exercises for 4 weeks. We have a special strengthening program for athletes. Full activity is usually reached at 4 to 6 months. In conclusion, important for the giant needle transosseous fixation is the positioning of the patient, doing a subacromial space, preoperative good planning, good mobilization, identify a tear pattern for anatomic repair, and use a good solid tying notes for security. Thank you very much for your attention.
Thank you very much, Dr. Bassem, for your nice presentation. I think we're going to move to questions right now, because I think still Dr. Kovacs has problem with these.
Yes.
Are you ready, or I think you still have a problem? So we move to questions. My first question to Dr. Assassi, actually, as regard the history and development, we noted that there are different types of anchors, and companies are just inventing new anchors. Your opinion, do you think we need these new anchors? Are they different from the old ones, or just the companies are just doing their effort to push us to buy their products? I mean, now there are peak anchors, before titanium, and different kinds and sizes and etc. So what's your opinion about that?
I use anchors and use giant needle, and later I do all my cases of rotator cuff by giant needle. But in some cases I can't use giant needle efficiently. So in small tears and in cases of like pasta, I can use anchors. Also, I used to do both anchors and giant needle to be familiar with both techniques. Really, giant needle is elegant technique and very rapid and cost.
So you're not using anchors. So most of the
nowadays,
time
about 2 years, I don't use anchors in rotator cuff at all, and always I use giant needle. But in the past, before 2 years, I used to use the double row by using the swivel lock anchor by Orshaus. I do the middle row and use the swivel lock anchor. I was familiar with this anchor. I love this anchor because.
Okay, perfect. So I understood. Now my question to Dr. White. Where do you put your anchor? Where do you prefer to put your anchor, medially or laterally in single row? So what's your choice? Would you please unmute Dr. White?
So the question was, where do I put my anchor, medially or laterally?
Yeah, which position do you prefer?
For me, it entirely depends upon what the tear I'm trying, what the tear configuration is. Practically, of course, with a positive repair, it's got to be medial, right?
Right.
That's the space that you have. I mean, ultimately for me, I want to maintain as much space on the footprint available for healing, because although there's some debate about vented anchors and whether the tendon actually heals at the anchor site, we're really trying to get the healing on the tuberosity. And so for postural repairs, practically it's medially. It's just where you would put it. If I do, the only single row kind of small full thickness repairs, I put the anchor laterally to give me, a larger space and footprint medially to heal. Those tendon tears, those small, sub-centimeter or centimeter full thickness tears, they're not going to retract. There's enough tendon intact that you're not going to have a retraction of the tendon. And so I'll put the anchor laterally. Now, the other situation where I'll use a single row is if I have a massive rotator cuff repair that I can't retract. And I do agree that tension and over-tensioning the cuff is not a good thing. And so if I have to medialize the footprint, I'll put the anchor more in the middle portion of the footprint, but I'm actually medializing the footprint to get that surface area for healing, kind of a medial situation. So that's where I'll place my single row anchors when I use them.
Do you believe when you put your anchor laterally, do you believe that there will be a contact area with the footprint? I mean, there's going to be a healing?
Well, with the arm and adduction, there will be, so with the arm in the sling and at the side, the pressure, there will be contact pressure between the medial tendon and the footprint. And I've had some situations predominantly for, post-surgical stiffness where I've reoperated on these patients. And I've also, I'm, one of the, as we all are, at a tertiary referral center. So I see patients referred to me that have had single row repairs, that the lateral based anchor, and the tendon will reconstitute over the medial footprint. I've seen it time and time again if you place that anchor laterally. So it whether there's firm secure fixation on the medial footprint, it still heals there. And at least that's been my experience with small full thickness tears.
Okay, in double row, do you prefer TOE or the classic double row?
I'm sorry, was that for me again?
Yeah. What kind of repair do you prefer?
I like the TOE. I do like the Transosseous equivalent. I do, and I realize the advantages are I think they're more than just theoretic. I think I think there is some support for the Transosseous equivalent being superior. Now, I will fully recognize, just like I said, the summary of those meta-analyses I looked at said functionally in their clinical outcome was no different between a classic double row and a Transosseous equivalent. But just it makes sense to me theoretically, and I think there is some biomechanical data that it is superior to the classic double row. And frankly, it's easier. I mean, you don't have to tie another if you're a person that tie knots. If you're using a knotless lateral row, which we are when we link the our medial sutures to our lateral row, it's just a quicker, easier process to do a Transosseous equivalent.
Okay, thank you very much. Okay, now Dr. Sanders, would you please unmute? So I have a couple of questions for you. How do you do your technique for subscap tear?
For subscap, usually I do 2 tunnels with triplets, so 6 sutures, sometimes more. And I'll usually simultaneously tendonitis the biceps. The bone in the biceps groove is the hardest bone in the humerus, so I don't have any concern about that. Passing simple sutures under the strap muscles it saves time and is easier, and so I do 2 simple tunnels for subscaps.
So what are the kind of the instruments? I mean, which company that produce this instrument that you're using? Is it the Arthro Tunner, like Tournier?
Tensor Surgical.
Okay, so just... I'm sorry again?
Tensor Surgical, TENSOR.
Yeah.
Surgical.
Okay. We saw so many sutures. You just you showed us so many sutures just above the tendon. You're not afraid of the vascularity. You're not afraid of just so many pressure on the tendon that may affect the tendon vascularity.
Certainly, no more than I would be with transosseous equivalent. I mean, I did transosseous equivalent for years, and I try to fix I think if you're making multiple fixation points, especially if they're simple sutures, you're getting very little strangulation, and you're not getting that over tension. When you're putting down with the mallet, the lateral row, I think that's way too much tension. Even compression, I mean, it may look good on a testing machine, but that's non-physiologic. That much pressure with a mallet. When you're tying with a knot, I think you're not going to over pressurize the tendon. The blood flow comes from the bursa and some from the tunnel, but a lot of it comes from the bursa, actually. And I don't think we know. That's a fair point. What about Mason Allen sutures? What about linking? Is it too much, or do you want to seal off the synovial fluid? There's a lot of questions there that could be fun to discuss. But I think when you're tying the knots by hand and you're not pressurizing them with mallets, you're not vascularizing it.
Yeah.
Yeah, but failure. One of the reasons of that. I'm sorry, because Dr. Kovacs, could you please unmute, please, Dr. Kovacs? Yeah, thank you. So I was just saying that type 2 failure in the muscular-tendon junction, it's caused because you're using knots, as you're saying. So because they're saying that you may strangulate the tendon and you may affect the vascularity. So it's just a question that came to my mind with after seeing so many sutures. I'm just afraid that it may strangulate the vascularity or the blood vessels, and affect the tendon vascularity. So that's why I asked this question.
I think the number of sutures is linked to the strength of repair. And so most surgeons have concerns about that. And that's why I developed that technique. I have never seen in hundreds of patients of that technique a type 2 failure. And I've had anchors right next to transosseuously where they fall and they transect at the anchor. Mm-hmm. So the transection, in my opinion, does not come from strangulation. It comes from excessive modulus of elasticity. It's too stiff. It comes from focusing all the pressure of the repair to that one fixation point of the anchor, where you have 3 sutures pulling to one anchor, and it's focusing all of the pressure on that one point. It's not really the sutures per se, it's the force is focused there, just like poking a pin through something. Whereas if you have multiple sutures separated by 1 linear centimeter for each tunnel, each suture separated, I'll do 8, 10, or 12 sutures, and then they're not strangulating at all. They're load sharing.
Mm-hmm. Okay.
And the simple sutures, I think, don't strangulate at all. Maybe there could be some strangulation with the bridging sutures, but I've never seen that clinically, so I have not worried about that. Most surgeons in the U.S., when they criticize, repairs, they want more sutures, more strength, etc.
Okay, thank you. Okay, Dr. Srikumaran, are you still with us? Dr. Uma? Okay, I think he just left. So, okay, my question to Dr. Flega. Can you hear me?
I think that Dr. Kovac is now ready to make his presentation. So, if you bring first Dr. Kovac and then we continue, or up to you.
Okay, we can move to Dr. Kovac and then we'll move to our questions.
Okay, I'm ready.
Okay, perfect.
So I see. Yes, I'm in now. So thank you. The next, please. Sorry for that. So I just to present me, I granted this clinic 8 years ago, and in this time we make 36,000 surgeries, and I make 550 shoulder surgery per year, and more than 11,000 in the last 18 years. The next, please. The next. Yeah. So we know the anatomy factors. I think it's not a question for tonight. I will speak about the rotator cuff because this is the most important thing for tonight. The next, please. I try to be quick. The Coleman cadaver examination, we know he found in 100 cadaver 61 rotator cuff without any surgical or treatment disorders. And I think a lot of people has rotator cuff tears without any symptomatic, but I think we should speak about the symptomatic patients. The next one, please. So the patient's way is examination and ultrasound, MRI, and we should decide if they need a surgery or not. We begin always with an arthroscopy, and then we go to a total joint implantation. The next, please. I think the ultrasound and the MRI is the most important for us. So every patient gets an X-ray and the ultrasound and the MRI, and we can decide if they need a surgery or not. The next, please. We have some protocols for all the patients and for the instability or the rotator cuff tears. The next, please. Our indication guide is we focus on the outlet impingement with acromion form and osteophyte, and all the patients with a rotator cuff rupture, they are symptomatic or partial rupture. They will get a recommendation for the surgery. The next one. So for me, the curved acromion type 2 is one of the interesting anatomical situation for the surgery, because the patients, I think, they will need earlier or later a surgery in their life. This in the left, this anatomically situation what we see in the surgery too. The next. We have a great range of indication for our surgeries. I think we make all our lesions arthroscopically. We don't open any shoulder in the last 20 years. The next, please. So 80% of the surgeries are performed because of the rotator cuff rupture. And this is the our particular patient group for tonight. 90% is treated is a satisfactory result after this surgery. And however, I think 2 to 8% of the patients have continued to recurrent pain or weakness following the arthroscopic rotator cuff, and they require another surgery too. The next, please. Some statistical data from Germany. You see on your left, the open operation was 59,000 in 2005. Nowadays is 48,000. Even it's a huge number. I think this surgery is. I think we should make it arthroscopically. I don't think that 2020 we should open a shoulder because of the rotator cuff tear. The next, please. I use the Cofield classification for the rotator cuff tears. The next, because it's easy to understand for the patient to make a difference between a small, medium, and a large rotator cuff tear. The next, and of course the next. Yeah, this is the picture what I show the patients to understand the different type of tears. The next. And of course, the massive rupture with all the retraction, atrophy, and probably fatty degenerations. The next. However, the factors influencing the results are the joint motion before the surgery, the size of the tear, the condition of the muscle of ruptured tendon, and the concomitant shoulder diseases, muscle strength, and of course the quality of the reconstructions. 80-90% of the cases are success and excellently resolved. The next, please. So we need some technical requirement and expectation. We need, as we heard, a primary fixation and stable and correct anatomy reconstruction. There are on the market a lot of fixation techniques, just 2 or 3 from this. I am very comfortable with the giant needle technique. I think this is the surgery which made the most strength fixation. The next. Because almost all the other procedures involve screw implantation with no specific complications such as displacement, dislocation, or loosening of the implant. I see a lot of patients which I need for the second operation to me make in another hospitals, and the loosenings percent is very high. So for me is the only technical method, the giant needle, which provides the complete refixation and without any implantation. The next. The giant needle technique was described by Dr. Pfleger, 2002. He has been using the technique since 1919 as an alternative to the open surgery, as we heard. So the underlying idea from him was this technique that with these special needles, the suture passed through the tendon and bone, or tendon to bone, unrestricted by any portal, and simply passed through the skin, tendon, and bone in one step, tying a knot in another step. But the most important thing is, for me, I think, is that we don't need any hardware implants for the surgery. The next. So this is the situation where you see the rupture and the anatomically preparation for the supraspinatus, and with yellow you see the most possible tears what we have. The next. So this is the, you can see how we pull the giant needle to the skin and the supraspinatus and the bone. The next. And yes, I put my name there because of this almost 12,000 surgery with a giant needle after Dr. Frega. But this is, he just presented the surgery, so I don't have to make it twice. But I think it's a technique which is very comfortable, and yeah, we have very good results. The next. So you see how we pull the thread through the to the tendon and to the bone and make the knot. The next. It's very important for me to make the bone refreshing. If you can see, if you can show us the film, the video. Okay, then. Yes, please. So this is what I want to see, the bleeding. Yes, the next. Massive rupture. You see the biceps, and the one step to another with the treat, so we can make more 3, 4, or 5 nodes to get the rotator cuff together with the bone. The next, and you see on your right how it make the nodes one after the other. The next. And if I see that it's a small part which is not coming together, I can make a 4th or a 5th stitches, and we have the complete reconstruction of the tendon. The next. Another advantage of this technique is that we can make intra-articular incomplete ruptures too. The next, you can see how I put the giant needle to the capsule intra-articularly and make the node outside from the capsule, but you see the fully reconstruction. The next. Tendon to tendon, it's a 20-second result. It's very quick and good technique. The next. Another tendon to tendon situation with a complete refixation. The next. So the giant versus screw, I know it's always a problem, and it's a question. The next, please. What I see sometimes, the problematic is that we can't pull the retraction to the bone, and you can see on your right down, it's not a fully contact to the bone. The next one. So I can bring together the two parts of the rotator of the tendons and try to pull the tendon to the bone. The next. Anyway, it's you see the screw. The next one, please. And I think almost is necessary to complement with a giant needle fixation, and the two techniques together bring a better result than just one in such a cases like this. The next. So the advantage of the giant needle technique is a strong fixation. I want a strong fixation. Anatomically and strength of cuff fixation. We don't need any implants. We can make tendon to bone, tendon to tendon, and intra-articular sutures, and it's compatible with any other technique together. The next. So the first 10 years results after 5,600 patients. So we have 81% of rotator cuff reconstruction. The rest was labrum and tendinitis calcarea or capsular rafting together with a labrum refixation. The next, please. Average years was 90.
Dr. Kovacs, it's time, please. So
yeah,
can you hurry up, please?
Yes. The next. Then. Okay, so you can see the results. I mean, we have 3% poor results, but the rest is good or excellent. Okay, thank you very much, and sorry for this complication.
No problem. Thank you very much, Dr. Kovacs. It was a really nice presentation. So back to the question, Dr. Uma. I don't know if Dr. Uma Sri Kumaran is still with us or not. I think he left. So question to, yeah, he left. He's not answering anymore. So Dr. Bassem, my question is, with your giant needle, do you use anti-bond or other kind of sutures with your giant needle technique?
Well, usually we always use the non-absorbable ethibond or polyester, and also in some cases absorbable sutures. So there are two types of needles, one with absorbable and one with non-absorbable, number 2. And now we have using a new needle in which you can put the suture you like in the needle. So the type of suture now is variable. You can use the suture you want.
And it's available in Egypt because someone was asking this question. Is it available here in Egypt? Yes, it is. Okay. So what about the bone quality? Or does it make you, if you have a poor bone quality, or for instance, a cyst in the greater tuberosity, does this change your technique or decision? How do you deal with that?
Well, first I want to say that the transosseous fixation has few points which are, in my opinion, very valuable compared to other types. First, it is saving the vascularity. You don't need to use to offer space like in anchors where you disturb the vascularity. You have a very good contact area between the tendon and the bone, and a big area of tendon bone fixation. And osteoporosis is not a contraindication for transosseous repair, in contrast to other techniques using material like anchors and so on. And also, the revision of failed repair is much easier than if you make a revision in cases of suture anchor where you have many holes and try to fix the tendon in it. Same thing with the cyst, as you said. So we clean the cyst and we try to fix the tendon on the solid bone areas around the cyst, and also make holes in the cyst with the hope that it will fill afterwards, if it is a small cyst, of course.
Yeah, but if it's a big cyst, you're not afraid that you may have that suture that it may cut out, or the bone that may break?
I had some cases where there's a large cyst under the greater tuberosity, and what I did, I cleaned the cyst, and then I have a gap in the bone, and I sutured the tendon in this gap. This will give me a good tendon bone fixation, but it will affect the range of motion slightly afterwards. But I think this is a compromise which I have to take.
Okay, perfect. Okay, Dr. Kovacs, I would like to ask a question. Some surgeons prefer to do cortical augmentation. So would you do that, or do you prefer to do that, or you never do that?
I never do that.
You don't believe in cortical augmentation?
No, not really. No.
Okay, and you never had any problem like the suture that cut out or the bone that broke?
No. I think it was a good question to Dr. Pfleger with a big cyst, and I think that's a real problem. If I have a big cyst, I'm afraid to break the bone, but otherwise I don't have any problems with the bone, with the corticalis. So I mean it's for me okay.
Okay, so now my question to all the panel, because I think we're running out of time, so we don't have enough time for our case presentation. So my question to the panel, what about acromioplasty? Do you prefer to do acromioplasty in all your cases of rotator cuff repair, or you just in some cases? So we start with Dr. White, Christopher White.
For the majority of cases, I will do acromioplasties. I think part of it is for access. Part of it is also that I think there's some suggestion that those stem cells that you release from the bone itself might actually help healing. I do have concerns, though, that if I have a real massive rotator cuff tear, I may be less apt to do an acromioplasty, because if this patient goes on to not heal, I don't want to destabilize the coracoacromial arch. But in general, for most patients, I'll do an acromioplasty.
Okay. Dr. Sanders?
If needed for exposure, or if there's a keel spur with obvious extrinsic compression, I usually don't do them in younger patients as well. So I do not do them on all cases.
Okay. Dr. Pfleger?
Thank you very much for this question. Actually, this is the subject of our webinar in April. For me,
okay.
For me, we did a study in the 90s on about 450 cases, and we used a measuring needle in the standards where the patient, as I showed, is sitting with the arm hanging, and we measured the space between the anterior acromion and the tendon. And we found that there is no impingement pathology or, say, rotator cuff tear in cases in which the space is more than 1.2 centimeter. So since then, we are using this technique to make a subacromial space distance of 12 millimeter. So if the space is less than 12 millimeter, I do an acromioplasty to get it more than 12 millimeter. If it is already more than 12 millimeter, which actually is very rare in cases of rotator cuff repair, unless it is a trauma or something else. It's not an impingement tear. So of course, we don't do a decompression. So the decompression is depending on measuring the space between the anterior acromion and the rotator cuff with the patient in a sitting position under anesthesia and the arm hanging. And these are the standards which we are using till now.
Okay, Dr. Kovacs?
Yes, that's what I learned from Dr. Pfleger 20 years ago. Yes, okay. I don't make an acromioplasty by a young sportsman which has a traumatic rotator cuff rupture, but otherwise, yes, it's.
Okay, Ceci?
I do when the space is narrow, and I do for exposure and make easy access to the rotator cuff. But if in young patient athlete, I don't do acromioplasty usually.
Okay. Well, one last question before leaving. My question is, we all know that the natural history of rotator cuff tear, that there is progression of the tear, etc., and it may end with rotator cuff arthropathy. And we also know that some patients with rotator cuff tear are asymptomatic and others are symptomatic. So what if a patient, young patient, like 50 years old, present to you with a rotator cuff tear with slight pain, but the range of motion and the force, everything else is normal. Do you operate this patient for fear of after that he may go into progression and then rotator cuff arthropathy, or you just recommend conservative treatment for him? So this is my question, because many participants ask about the role of conservative treatment, despite that we all know the natural history of the rotator cuff tear. So, Dr. Brett Sanders, can you answer me? What would you do?
So you broke up a little bit, but I heard a small cuff tear that's relatively asymptomatic or minimally symptomatic. Essentially, depends on a lot of variables. That's a tough question. I think if they have weakness on exam, I'm more prone to surgically fix that. If I can detect it on exam, they're not compensated well. These days, I tend to follow them with ultrasound and check them every 6 months if they have a clinical progression in terms of pain or weakness, or ultrasound progression, so that I can understand the rate of change of their progression. Then I would fix them, based on structural integrity rather than symptoms. Mm-hmm. I rarely fix an asymptomatic rotator cuff repair when they're asymptomatic, because then I think they get symptomatic from the surgery, and they don't appreciate the surgery as much.
Yeah, correct.
Follow them and wait until they were symptomatic, or wait until there was a progression on ultrasound or documented weakness on exam in the plane of the tear.
Okay. Dr. White?
So the case you presented for us was like a 50-year-old, is that correct? Like a full thickness?
Yeah, it's a young patient, just might be, yeah.
Yeah, I think that's a great question. I think for me, obviously, if they're seeing you and they're symptomatic, full thickness tear in a 50-year-old, that's age inappropriate rotator cuff pathology. I mean, we all know that as we get older, we see rotator cuff disease and rotator cuff tears that are asymptomatic. In fact, most folks, over the age of 60 or 70 that have cuff tears are asymptomatic. But in a 50-year-old, that's pretty progressed pathology. I think I would, discuss with the patient if they were symptomatic. If they were totally asymptomatic, that's even a more difficult question, I think. But if they were symptomatic, because I agree, you can't make anybody better than asymptomatic, right? So in that case, I think following them with imaging makes sense. If they were symptomatic in 50, I would talk to them about the potential of cuff, because that's kind of age inappropriate pathology. And I talked to them about the potential of cuff progression and problems down the road, and discuss their options. And if they wish to not to proceed with surgery, I think you would probably, monitor that either clinically or by imaging. Okay.
Dr. Kovacs?
Yes, I think I would wait. Make a control every 6 months and see how, because if she or he has a weakness or any symptomatic, then yes, but without any symptomatic, I would make any every 6 months a control.
Okay, Dr. Frega?
Well, actually, if the patient does not have symptoms, they will not come to me to the clinic. That's
no, just pain, just my pain.
So yes. He may have a slight symptoms, a slight pain, and he was to have my advice. Whereas when I tell him you have a tear and it is progressive and it must be operated, he said, no, I don't want. So I discussed that with him. I asked him what are his activities. If he wants to play tennis, I tell him you have to stop tennis. You have to be calm. Don't do overhead activity, and you can wait and see till you can not bear it, then come back to me. But if you want to continue doing your activity with sport, there is no way you have to do the surgery. So I give the decision to the patient. I just explain to him the progress and explain to him how it will be in the future, and he has to decide. Some patients say, okay, I'll stop my activity, I stay like this, especially old patients, and I wait and see because the symptoms are mild. Some say, no, I want to do sports, I am an active patient, so I will do it. But if he has really pain, he will do it.
Okay.
So that's I discuss with the patient, let him decide.
Okay, Dr. Aksesi, do you have any comments?
I don't think young patient with full thickness tear is not symptomatic. Always will be symptomatic, but if he really asymptomatic, I will then touch him, and I follow up him every 3 months or 6 months.
Excellent. So I guess we have reached end of our webinar. I would like to thank all of you for your assistance. It was really fruitful for me. I really enjoyed. I hope that I wasn't not that mean to any one of you. And I just would like to wish you to be safe during this pandemic. I hope you and your beloved stay safe, and wish you to see you in our next webinar. Thank you very much. I really enjoyed, and I would like to thank all doctors, all speakers, and the participants. And also, I would like to thank the CUB, the company that made this possible. Thank you all, and good evening, good night, or good afternoon, wherever you are. Thank you very much.
Thank you, Dr. Ahmed. Thank you, our guest speaker.
Thank you. Bye.
Thank you. Thank you. Bye.
You hear me?
Yes.
Okay, I want to thank also Dr. Ahmed for his wonderful moderation, and thank Chris, Brett, Omar, Georg, and also Mohammed for their wonderful presentations. And I want to just announce that our next webinar will be also on a controversial subject, is the arthroscopic inferior capsular shift versus suture anchor fixation in case of recurrent anterior shoulder dislocation. Thank you very much, and see you next month.
See you. Bye-bye.
Thank
you very much.
Thank you. Goodbye.